Assalamu alaikum warahmatullahi wabarakatuh. Welcome everybody after our heavy lunch. I hope that everybody is awake so far. We'd like to start our third session today. The session will be about the lessons from the bedsides, and the session will start with Prof. Abdurrahman al-Nimri. Prof. al-Nimri is the professor of pediatric and consultant neonatologist in King Khalid University Hospital. He's also the chairman of the Saudi Neonatal Society, and most of you, I believe, knows Dr. al-Nimri. So I shouldn't speak too much about him. His name speaks about him already.
طيب. Saudi and Argentina is 1-0. And I will feed you back after the end of my lecture. Halas, one is off. طيب. The organizing or scientific committee, they put me on this subject, listen from the bed. I say in ICU there is no bed, there is incubator. For maybe listen from the incubator, or maybe he mean the beds of the at home before you wake up. But I will give you some lessons, and I don't know from where, but you will learn inshallah from it. So I go to my publication for this lesson, which is case reported. So I found maybe there is more than 20 case report I had reported in my academic career. So which one I will choose? They told me they have only 20 minutes. How many minutes we have? 15? I will make it 10 minutes.
10 to 15, please.
10 minutes. I will make it 10 minutes. So I'll choose only one case. So this is the first lesson we learned it, that الموت والحياة ليس بأيدينا. الله سبحانه وتعالى هو مالك الموت وهو مالك الحياة. فما نحن إلا أسباب. This is the case of full-term baby admitted, born spontaneous vaginal delivery, 3,000 grams. He get meconium aspiration syndrome, sustained mild hypoxic ischemic encephalopathy. Umbilical venous catheter was put in the delivery rooms, resuscitated nicely, brought to the NICU with stage 1 hypoxic ischemic encephalopathy. And actually he did very well. So a couple of hours, we were able to extubate the baby. He is off inotropes, and he is almost on the second day of life. So you made the parents, we are happy. You make them happy that the baby is sustained stage 1. Most of the time they will be fine neurologically. So we get to go home. Like, unfortunately, at 36 hours after I counseled the parents actually, and I was there in hospital. So when I step out in the parking, my resident called me, come, the baby is suddenly collapsed. Deciding badly to the 50s, heart rate is only 50s, and the baby is dying. I just talked to the parents. So I came out, حتى الحمد لله I didn't drive to have مخالفة ساهر. So I came from parking, running to the units, and I found a dead body in front of me. And my thinking that time, what could be the cause? What I will tell the parents? I just told them that the baby extubated and he is fine and he will be fine. في هذه الديلما, I picked up the ultrasound. I hope Yasser Said is here. And the ultrasound, first thing I'll think about it, maybe he has a bleeding. It's a weight. Bleeding in the head. So I did ultrasound for the head, is normal. So maybe he has a duct-dependent lesion. The duct closed and he collapsed. So I have just few experience in the duct, how to see the fourth chamber and the great vessels. So I just did echo by the ultrasound only, and a huge balloon of water in the heart. What is this? So my resident was there, wanted to do paracentesis. I said, okay, but do we have the privilege to do that? I said, no problem, the baby is dying. Just I get the needle, stick it, and around 35 cc of fluid come from the pericardium. And alhamdulillah Rabbil Alameen, the baby start to have increasing the heart rate to 100, 160, saturation start to get up to 90, 95, 100. And the baby survive. So the question was, what caused that pericardial effusion and cardiac tamponade? Anybody can guess? Percutaneous line, he has umbilical line. And we confirm it by the X-ray as it was in the normal position. This is the first X-ray after we insert it. It is just above the diaphragm. Sometimes migrate, mashallah, good student. Professor Saad, you are right. So when I did another X-ray after, we get pericardial synthesis, and this is the umbilical line which migrate higher than the T8, T9 almost on the right atrium. And then we report this case as a rare but fatal complication of the UVC line. We are using UVC line more common than anything in our unit. We train our resident to do it rightly. We give them the recommendation, what is the position to keep the line just above the diaphragm at T8. And we make sure before you infuse anything TBN to make sure the line is in the right position, just at the junction of inferior vena cava and right atrium. And that's what he did for this baby. Okay? Lakin we never expect the complication of this pericardial effusion. Although it has been overlooked in the literatures, and I don't know why, because maybe the child or this neonate died from the cardiac tamponade. Nobody raised the flag, and for me it was by chance. And it doesn't come to my mind, to be honest with you. I just did my ultrasound for the heart, looking for duct-dependent lesion, وكان رحمة ربنا إن إحنا شفنا pericardial effusion. Maybe there is a lot of baby, when we have one, collapse, died, they don't respond to resuscitation. You resuscitate them from now إلى يوم القيامة. I don't think that it will recover if you don't do pericardial synthesis. Like pneumothorax. We think about pneumothorax, but the baby is already extubated, unlikely to be pneumothorax, but we did transillumination and there was no pneumothorax. So how the UVC line reached to the heart? There is the theory of migration. How do you migrate? Maybe by the junction of the gel موجود في الumbilicus, or maybe by the time the child improves his lung and the lung expansion, lung volumes get improved in a premature baby, the lines will go there. Or maybe nursing problems. We don't fix it very well. So every time they get infused, 1 cc or 0.12 cc will go in. So the migration has been postulated as one of the theory. The other theory, maybe they said it is just by the infusion of isotonic solution. So like you are rushing by the pipes in any wall, it will get hork. But the same thing, if you are running that infusion pumps by 3, 4, 5, 6 for almost 24 hours, 48 hours, I think the myocardium will get injured and the lines will get there. But there is no blood in this pericardial effusion. You expect some blood to be there if this is the theory. The new recommendation now is to use the ultrasound guided lines. So you put the lines, and by ultrasound you will visualize where is it. More quick, and I hope Yasser is here. These groups, they said more quick, less radiation. You don't delay the infusion pumps, so you put the lines, and within minutes you will know where is the lines, and you start the infusion pumps immediately. So now this is the new recommendation for putting umbilical lines. So even the Infusion Nurse Society, they had recommend this child has all this aseptic technique. In addition, they recommend also to do ultrasound, quick tools to identify what is the tip of your UVC lines. So what is the lesson we can learn from this? I put for you 6 lessons from the bedside or from the incubator. Maintain the high level of awareness of the catheter tip position. Ultrasound guided insertion is better than the hazard of radiation, which delay your infusion pump. One must adhere to the recent guidelines. Be aware of the possible complication, especially the cardiac tamponade, and raise it always in your mind in the literature. The UVC line can cause that, plus percutaneous line, plus any central line. This is my lesson. This is my 10 minutes. Thank for your listening, and I hope our muntakhab, inshallah, will do it at least 1-to-1. Shukran jazeelan.
Our next speaker is Professor Saad Al-Saadi. I think everybody knows Professor Saad. He's a professor of pediatrics and neonatal medicine, and now he's at King Faisal Specialist Hospital, Jeddah.
Assalamu alaikum wa rahmatullahi wa barakatuh. Just because the time, the title of my presentation, A Long Journey from Intrauterine Life to Home, the importance of the team work. And I would like to stress on this. Our case is the following. 34 weeks pregnant Saudi mothers booked in King Abdulaziz University Hospital. Antenatal ultrasound revealed huge neck swelling, which is almost the size of the fetus. There was some evidence of compression on the upper airway. So the perinatologist asked for a meeting which involved the neonatologist, ENT, pediatric ENT, pediatric surgery, anesthesia, to plan for labor. The recommendation of that meeting was to follow her up until the gestational age is 38 weeks, and then to do elective cesarean section with exit procedure in the presence of the whole team, which include neonatologist, ENT, pediatric surgery, anesthesia, beside obstetric. Exit procedure stand for in utero intrapartum treatment. So, exit is a procedure where there is a special delivery performed when it's anticipated that the newborn will have upper airway compromise once separated from the mother at delivery. So the purpose of the exit is to provide the necessary intervention to the baby before the umbilical cord is cut, avoiding the crisis of upper airway obstruction. So it's just the delivery of the head from hysterectomy, keep the rest of the body in utero, do not clamp the umbilical cord, and in this position you try to intubate if possible. If intubation is difficult, you do tracheostomy and then deliver the rest of the body and cut the cord. Unfortunately, ما كل يتمنى المرء يدركه تجري الرياح بما لا تشتهي السفن، أو في قول آخر السفن. On a Friday morning, at 30 weeks gestation, she came to the emergency with some evidence of early labor, admitted to the OR. Immediately from the emergency, the team was called. And this is some of the team. This is the neonatologist, the obstetrician, as well as the anesthesia. So, this is the baby once delivered. If you could see a huge neck mass involving most of the neck and the right upper shoulder and pushing the head to the other side. It's a good thing that we were able to intubate the patient, though subsequently, for security reason, later on when the patient admitted to the NICU, according to the advice of the ENT, that to do tracheostomy under control condition, because if this tube comes out suddenly and very difficult to re-intubate, so maybe jeopardize the patient's life. So this is endotracheal intubation immediately, but be replaced later on by tracheostomy. So what is the subsequent management? Cystic hygroma in the posterolateral side of the neck. MRI showed no intracranial or intraspinal or intramediastinal extension. Frequent cyst aspiration through a catheter was done, and the cyst was excision was done at 35 days old. Also, sclerotherapy was started, where bleomycin injection was sort of sclerotherapy was started. But the patient was ventilator dependent. So bronchoscopy at the age of 110 days showed suprastomal as well and lateral granulomatous tissue causing obstruction, about 60 to 70% obstruction. So bronchoscopy in between, we used bleomycin injection, intralesional injection, repeated at the age of 6 months and 1 week, showed no suprasternal granulation and no mass effect, so decannulation was done, and the patient discharged at the age of 5 months. And this is at the time of discharge, the baby with his father, and this baby also with the mother. This is the first case. Case 2, this is in King Faisal Specialist Hospital. 31 years old pregnant Saudi female, came at 35 weeks gestation. She was referred because the same problem, because of fetal neck cystic mass. Here MRI in utero was done, showed large septated cystic lesion measuring about 14 by 9 by 13 centimeter, consistent with cystic hygroma of the neck. There was no evidence of severe compression of the neck, according to intrauterine MRI. Amniocentesis was done, which ruled out showed normal fetal karyotype. Fetal echo showed no signs of congenital heart disease. So, again, multidisciplinary meeting was held where a whole team, including pediatric surgery, ENT, anesthesia, and others, and decided that the team meet every week. We took an extra step. We did a mock delivery. We using mannequin and went to the OR, and this is what we found this in the literature, where everybody stand. So if you see the mother at the middle, the color coded, the different subspecialty, where do they stand? Anesthesia, ENT, neonatologist. This scheme also showed if you are going to use ECMO, for example. So we used the same one. We went to the OR, and this is actually the mock in the OR. Everybody knows his position and her position. And this is after we finished the mock. And I think you know this neonatologist, one of our colleagues. Again, we are planning to deliver her a cesarean section at 38. But at 37 weeks, she came in labor. So the team was called again. And cesarean section was done. Neonatal head with the mass was delivered, while rest of the body was still in utero. Intubation was done successfully. Umbilical cord was cut. All were performed within 4 minutes, which is really a good time. Yeah, recommended that time from 5 to 6 minutes. But I think very important to do it within 10 minutes, because you know, one issue when you do anesthesia to the mother, you give her some sort of inhalation anesthesia, which make the uterus relax, so easy to deliver the head. But there is a side effect. When there's a side effect, if you take a long time, the separation of the placenta, hemorrhage. So this anesthesia, inhalation anesthesia, is very important, but you have to do it less than 30 minutes. So the patient born within 4 minutes, and was taken to the emergency. So the baby boy, birth weight 4.1 kilogram, neck mass, huge one. And this is the, if you could see how big the mass, which is most likely cystic hygroma. This is another view from another side. This way they're going to start IV. So aspiration of the cyst, the first aspiration done immediately, 20 mils per kilo per kilogram. And the view of the opinion of the surgery that we are not going to do surgery, to just start bleomycin 0.5 milligram per kilo was given inside the lesion. One of the side effects of bleomycin that it causes irritation. So there is accumulation of the fluids in the lesion. So that's why we decided to give more, after that, short, less dose with more frequent interval, and the same time to insert by ultrasound guide a catheter there to every day will aspirate certain amount. So this is the catheter. 2 weeks later, we reduce also the dose of bleomycin. After 6 months, it has been shown that almost complete resolution with redundant skin. So here we haven't done surgery. So this, the baby, before discharge, you could see the wrinkling of the skin. We discharge a patient with follow-up with plastic surgery and with pediatric surgery, and the plastic surgery gave him an appointment after 1 year to correct this wrinkling of the skin. So cystic hygroma is one of the most common benign congenital lymphatic malformation, and it's due to embryonic obstruction or sequestration of lymphatic tissue. It may be associated with some chromosomal anomalies like Down syndrome and Turner syndrome. 80% of cystic hygroma occur in the neck and in the mouth. Surgical excision is the standard treatment, but with the huge one, it's associated with a lot of investigations. You cannot remove the whole mass, scarring, you injure some arteries and vein, some nerve, particularly the huge like one. So here where the sclerotherapy and frequent aspiration come. Sclerotherapy, we use either OK for 32 or bleomycin. In the two hospitals, we used bleomycin. There is a lot of complication for this, edema, pneumonia, interstitial pneumonitis, and others. So it leads to complete resolution of cystic hygroma in 60% of cases. Only 30% of cases you have to do surgery. So let me just, because the time, exit procedure has different causes. First time it was used in the 1992, where to remove, one of the treatment or management of diaphragmatic hernia in utero, severe diaphragmatic hernia, they plug the trachea. So the fluid will accumulate and stimulate the lung tissue, so it will grow. So when the delivery comes, they have to remove it. So they use exit procedure to remove the occlusion and to deliver the baby. This is the first use of exit procedure in the 1990s. Subsequently, there are a lot of use. It can be used for airway procedure, different vascular or cystic hygroma and others. Also being used for resection, chest mass and other. Also can be used for conjoined twins, separation conjoined twins. also for ECMO purposes in some circumstances. So fetal intervention consists of endotracheal intubation, this is number one, or tracheostomy. Number two, mass excision, then removal of the temporary tracheal occlusion in case of diaphragmatic hernia, or ECMO in certain circumstances. So I'm going to stress here the importance of multidisciplinary meeting, team approach. Without it, you طبعا توفيق الله عز وجل, you cannot achieve the goal. Thank you very much.
So we'll go to the next speaker if he's available, because I think he will be online or through virtual. We'll check if he's available, or we'll take a small discussion about these two topics with the audience, then we'll proceed. We'll have a small discussion regarding the previous two lectures by Dr. Saadi and Dr. Nimri. Prof. Nimri would like you to join the stage for a brief discussion. Prof. Saadi is already here. So any question for Prof. Saadi or until Prof. Nimri is here? Dr. Saad, I'm having a question for you. You talk about the exit procedure and the controlled environment. What about if this baby's or such a baby came in an uncontrolled environment? What would be the approach? Do you have different approach for emergencies like this? For example, some of our colleagues might face in the non-central or non-specific specialist hospital such a case without any information from OB. What would be the approach at that time when the patient is there and having the delivery?
Thank you very much, Dr. Abdulaziz, for asking this very important questions, because the time I didn't go through. In my career, I came across 4 cases. 2 cases in King Abdulaziz University Hospital and 2 cases in King Faisal Specialist Hospital. The 2 cases who died who in the OR, we couldn't secure them in the 2 hospitals where unbooked, came to the emergency in labor, pushed immediately from the emergency to the OR. It's very difficult to arrange the team. One of them, the ENT doctor was there, but it was very difficult to him for intubate or even tracheostomy, because the tool is not there. Something come immediately, unfortunately. The success rate, as reported in the literature, exceed 70% under control condition. For this difficulty, Dr. Abdulaziz and the rest of my colleagues, the best you can do is to intubate or tracheostomy, but if you do everything rush, the failure rate is high. If the patient if she didn't deliver, you can't do the same team, but you call everybody. I remember one of the cases, the NT doctor came from home. He's not in hospital. Consultant, usually they don't take call in the hospital. Anesthesia. The 2 cases, we have pediatric anesthesia with us. In one of them, I don't know, I'm not sure about one case. The other case, we don't have pediatric anesthesia. The adult anesthesia we failed. So I think do your best, but the failure rate is very high.
I have a comment here. Sorry.
Go ahead.
Thank you very much, Dr. Saadi. But the question, as Dr. Abdulaziz mentioned, and it's not unusual, like mother unbooked or she came at the middle of the night, and with this case, we really encounter two cases. One of them has huge cystic hygroma, and unfortunately, those baby, one of them, he was spontaneously breathing, so it didn't need intubation. And even it happens a similar case in Europe, and even I have the video of that baby, he was breathing spontaneously. So maybe if the baby born and he was breathing spontaneously and no element of obstruction, please leave him alone and call the ENT and call the team to assign. Do not try to sedate and intubate the baby. The second thing, maybe if you have a baby who requires resuscitation and with that huge cystic hygroma, one of the recommended way is to use laryngeal mask airway in these cases. And it's because if you try to intubate with laryngoscope with this baby, it will be very difficult. So laryngeal mask airway is number one priority in securing airway for those baby who was born, accidentally or suddenly. And you need to have some assistance of ventilation.
Thank you, Dr. Jubara. One of the cases, the first case, it was very clear there is significant compression. But yes, the second case, the MRI, which is done about 4 weeks before delivery, it didn't show significant obstruction or compression. But, you don't play with these cases, particularly when you see a very huge swelling like those two cases. However, if something happened like this, it depends, as you said. It depends on how big the lesion, the location of the lesion, whether there is compression or not. But always try to be in the safe side.
Any other? Yes, please.
Thank you, Professor Saadi. Very interesting, very good cases, actually. My question is, what is the quality of life? I mean, sort of complications he encountered after. I mean, the following 1 or 2 years, definitely they might have some sort of upper respiratory or other problems in any way. What sort of thing did you see in this sort of patients? Because invariably they should have something anyway.
Thank you. This is, I think, a very important question. Also, because the time I didn't go to the details. If it's isolated, if there is no hypoxic ischemic encephalopathy around delivery, and if it's isolated, usually they are fine. In those two cases, we follow them until 3 years. And then after that, my colleague followed them. They were completely normal. The first case, he used to come every year with his father for prematurity day, because he's 35, 36 weeks. So usually we invite the father, and he used to come until the age of 5 years. And then I haven't seen after that. It's completely normal. Of course, the scar and this, but the plastic surgeon, they are very good in doing this thing. The second one, followed with pediatric surgery with my colleague, Dr. Usama Bawazir. Until now, he is telling me everything is fine. The second one, the case was to 2020. So by now, almost completed 2 years. Yes, please. Go ahead. Yes.
Yeah, Assalamu alaikum.
Alaikum salam.
Just a comment for the case report of Dr. Abdurrahman al-Nimri. We reported a similar case, if Dr. Abdurrahman is listening. We reported a similar case, me and Dr. Al-Alayan, I think in 1997, where we had a baby. Cannot hear?
He said
We can hear you. We can hear you very well.
He said Dr. Alayan and they reported 2 cases for
Yeah, I reported the case of
for
a baby.
for percutaneous line also we reported 2 cases. The problem
Yeah.
with percutaneous line, maybe the position is okay, but if you leave it inside the heart, it may migrate.
Yeah, it wasn't a percutaneous line. It was a UVC, similar to this case. But it was a preterm baby, and he developed or she developed right-sided pleural effusion. The baby was actually extubated and after treatment of RDS, and then suddenly he started to require more oxygen and intubated again, and the chest X-ray we did after intubation showed the right pleural effusion, which we needed to drain, and then the baby was extubated successfully.
Yeah. Most of the cases reported, as Prof. Asad said, is related to central line and percutaneous line. UVC there is some reported cases, but mainly in premature babies. And most of these are the one who infused them, and this is one of the message. You infuse before you know what is the tips. وهي المشكلة لما تكون you did X-ray and the X-ray shows the tips at just at the diaphragm. So the theory of migration, maybe many of us who don't really look for it, and that's why it's overlooked. Sometimes when we have a patient like this who's stable, gets suddenly collapse, and he has a UVC line, think about it. But the problem is you don't have a cardiologist in the spot always. So as the times you call the cardiologist, the baby will die. So the best way is just to get the ultrasound, get some just few on the heart, and pericardial effusion is easy to pick it. That's why it's overlooked in the literatures.
I think the point of ultrasound is very important, because if you do an X-ray, you do it in one plane. You don't do it like, you cannot see if the line is curving to one side.
Yeah.
Suppose that you do it AB, then the line may be going towards the posterior side. You don't know how long it is curving in. So that's probably one of the causes also. So ultrasound can give you a better idea if you have the experience.
Yeah, and it doesn't need experience. I just to visualize the tips and to see the 4-chamber fuse by just simple ultrasound. It's going to be very easy. وهذه زي ما قلت لكم هي رحمة ربنا اللي علمتنا ان هنشوف الهارت ولا we are almost going to miss the skies. And actually we miss a case like this exactly. And then maybe postpartum, if you have some studies, you will find a lot of cases like this. Allahu alam.
Any other question, please? I might have a question for you, Prof. Abdurrahman. So, sometimes you do the X-ray or you do the ultrasound. What is the recommendation of follow-up ultrasound or whatever?
Looking for the migration. خلاص, once the ultrasound is in your bedside and you get building up your experience, you can do it if you are infusing it daily, no problems.
So
part of your clinical examination.
But there was, is there any recommendation for
No,
daily or
no.
whatever ultrasounds
No,
follow up? Because you know.
Until now, they don't put any specific times for it, to my knowledge.
Okay.
But for me, I love this ultrasound to be in the units. You feel more comfortable. You look for the brain, you look for the heart, and if you get the experience to be hemodynamic, like Dr. Yasser is teaching now, that will be the best. So central line guided by ultrasound, umbilical lines guided by ultrasound, at least for the tip. And then the way they secure the tips, they put a bridge. Nowadays, bridge is just to not to allow the UVC to migrate more. So you do the bridging, and then you put this one with the tail. So that will not allow the UVC to migrate further.
Great. Yes, please.
Again,
Just,
thank you very much, Professor Nimri. What was the analysis of the aspirate you've taken?
It was the same like an IV fluid.
Pardon?
The same as IV fluid. It was an IV fluid, not TBN. So it was dextrose, the same concentration, the same potassium, the same sodium.
Okay, second question is, didn't you go to any sort of pericarditis due to this?
How is that? What do you mean?
Because of the chemicals in the TPN. Usually some babies, they react to foreign bodies with chemicals, this sort of calcium, this sort of thing.
Yeah.
Did that patient develop any sort of
That's why we don't run any,
pericarditis?
the practice not to run any infusion until you are sure.
Yes,
where
I know, but your patient, this is your patient.
Yeah.
What happened to this particular patient?
We unfortunately, we miss it.
Pardon?
We miss it, and we did ultrasound, and the ultrasound shows the first ultrasound that the UVC is in the right position. We're gonna run our TBN hatta, بس في الفترة هذه he's almost improving. That's why we remove the T-pin and we put him in dextrose. Otherwise, there is no any guidelines which solution need to be run through that UVC line. But the only message that don't run any solution T-pin or dextrose until you are sure what is the tips. If I get your point. خلاص.
We have one more question there.
اتفضل.
One last comment, maybe Fawaz Qashlan Military Hospital. We had many complications, either migration in or migration out, obviously for central lines. So reviewing the literature, we changed our guidelines that an X-ray will be done 24 hours after insertion, either if you correct the position or not. We do it 24 hours after and 1 week after, if it stays long time, to prevent something like this, whether pleural effusion or pericardial effusion. And the last case that we had, Dr. Wafa is not here, we were together, we just blindly tapped the baby the line was there, central line was there, baby was on TPN, and he suddenly collapsed. Transillumination was negative for pneumothorax and no time to do the X-ray, and he's hypotensive. And we tapped subcostal, and we got maybe 20 ml of TPN mixed with lipid. And the minute you see the lipid, you know it's really leaking from the central line.
Yeah.
Thank you very much.
Yes, good. But the problem, if you have the ultrasound, to be faster than the X-ray. There's no hazard of radiation.
Yeah,
So
yeah, you're right.
myself,
yeah.
and I want to build everybody to
Sure,
think
sure,
about it. Build
yeah.
up the ultrasound guided to visualize this. And if it is in the unit there, and you have the chance to do it for the IVH, you train your fellow to do it for the localization of this UVC line tip. خلصنا؟
Yeah. Any other question? So whenever you are asking a question, Dr. Nimri will surprise you with an excellent answer. Like our team right now, surprising everybody with the second goal on Argentina.
Second goal?
Second goal now. We are winning.
طيب, good.
Congrats, it is 2 for Saudi.
Yes, 2-1
1
now.
Argentine.
كويس. Let us finish by 2.
So let's keep asking Dr. Nimri, maybe we'll get a third goal right now.
طيب, we have our, go ahead.
Okay. So we just want to check if the... So the third speaker on this day actually is Dr. Joseph New. Dr. Joseph New is the professor, Department of Pediatric Division of Neonatology, University of Florida College of Medicine. We'll start our last session now with Dr. Joseph New. Dr. New is a professor in the Department of Pediatric Division of Neonatology, University of Florida College of Medicine as well. Because we are having shortage of time now and we are running late, we'll give the floor to Dr. New now. Please welcome Dr. New.
Okay, can I share my screen? Can you see my screen?
Dr. Qattan, can we have the two screens and the microphone from your side?
I have to have the screen enabled so I can share. I get a message, host disabled participant screen sharing.
We are arranging, the connection.
Okay.
And it will be a few minutes, inshallah. We will start.
Okay.
Those. Shakil, at least his photo should appear on the screen. Projected. Should be any there or photo like this. No, here. Come. It's there already.
Dr. Noor, can you hear us?
Yes, I can hear you.
And we can hear you very well, so we can start. Actually, we did the introduction part earlier, but maybe at that time there was a problem in the connection. So please proceed with your lectures, please. Thank you very much.
It still says host disabled participant screen sharing. There we go. Okay. Can you see my screen?
Yes, it's very clear. Thank you very much. So we can proceed.
The title says dysbiosis of the intestine in preterm infants. Okay, can you hear me okay now?
Yes, we can hear you.
Okay, very good. Good morning, good afternoon, good evening. I was originally asked to speak about probiotics in preterm infants, and I've decided that it would probably be more important to talk about a concept called dysbiosis, which gives a much broader idea of what is going on in the intestinal tract of preterm infants, and then talk about the possible role of pre, pro, and postbiotics. So that expands the lecture a little bit. The agenda over the next few minutes for this lecture, I'm going to talk a little bit about preterm and term infants' microbiota and what is dysbiosis and what is the difference between preterms and terms. I'll talk about implications for health and disease in preterms and also in later life. And then I'm going to talk about using dysbiosis to predict disease and then prevention and treatment of dysbiosis. So where do we get some of this information about dysbiosis? And classically, we were able to culture microbes very readily, but for the most part, in certain niches such as the gastrointestinal tract, soil, water, etc., we are not able to culture all of these the microbes that are present in a certain niche very well. But over the last 15 years, major microbiome sequencing technologies developed, and these are 16S sequencing and total microbiome DNA sequencing. The first of these, the more simple one, the 16S RNA sequencing, gives us an idea of the types of bacteria that are present in a certain sample. It gives us the relative abundance of certain kinds of bacteria, but it doesn't tell us what they are doing. The whole genome sequencing, or sometimes called metagenomics, gives us a much better idea of the overall microbial community and also gives us some idea of what they are capable of doing, not necessarily what they are doing at that time, but what they are capable of doing. So using these techniques over the last decade or so, we've gotten a much better idea of what is going on in the term versus the preterm intestinal tract and in the microbiota of the preterm and term intestinal tract. So here we have two pictures. Here's a mother and a baby, and this is obviously a term baby right after birth. And here at the bottom, we see a very preterm baby who already has lines in and is being mechanically ventilated. Very different looking babies. Well, the gastrointestinal tracts of these babies are also very different. And I just want to quickly go over some of these major differences. Here is the term baby, and in the term baby, you have a well-developed mucus layer. You have cells called the goblet cells, which produce a lot of this protective mucus. You have Paneth cells that are present in the crypt region of the intestinal tract that produce defensive molecules called antimicrobial peptides, which protect the gastrointestinal tract. And shortly after birth, what you see is in the term baby, a dominance of a certain phylum of bacteria called the firmicutes. These are considered to be good bacteria. And then as they start growing, the luminal oxygen begins to decrease, but this can be interrupted by intrapartum antibiotics and if there's a C-section versus a vaginal delivery. But for the most part, when we don't have these interruptions, you get a nice balanced microbial community. Here in this very preterm infant, you don't have this mucus. You have reduced antimicrobial peptides, and you have increased permeability between tight junctions. So in other words, a very leaky gastrointestinal tract. And the preterm babies are born with some microbes, and these also begin to expand. But preterm babies very often are born by cesarean section. Almost all preterm babies less than 1,200 grams get antibiotics administered to them. There's gradual feeding advancement, and invasive devices are placed on these babies. And so you get a different kind of microbial environment, largely populated by bacteria of the phylum, the Proteobacteria, which have a lot of lipopolysaccharide, or LPS, in their cell wall. There are several factors that can influence these types of microbes. But overall, the preterm microbial environment is very different than that of the term. That different microbial environment is called dysbiosis. And the definition of dysbiosis is an imbalance of gut microbiome associated with an unhealthy outcome. And this is also associated with the loss of beneficial microbes with the expansion of pathogenic microbes. And so here's a picture of the normal situation with gut homeostasis. You see microbes that are primarily commensal or friendly microbes. You see IgA, which immobilizes some of the potentially pathogenic microbes, and you don't have translocation of these microbes through the gastrointestinal barrier. With dysbiosis, you get a large production of potentially pathogenic microbes. Here we have the loss of the mucus layer. You have open junctions between epithelial cells. These microbes can pass through this leaky barrier, and you have a dysregulated immune response because below the epithelial layer, you have a very immunoreactive subepithelium. And when that highly immunoreactive subepithelium gets exposed to these microbes, it produces an inflammatory response. And this can be very damaging to the baby. So again, I just like to reiterate some causes of dysbiosis: poor diet, antibiotics, H2 blockers and opiates can lead to dysbiosis. Formula and donor human milk feedings versus baby's own mother's milk, and some of the hardware like tubes that we put into these babies' upper gastrointestinal tract. And also some of the endotracheal tubes can also cause dysbiosis. So what are some of the results of dysbiosis? Well, here is the diagnosis that we are very much afraid of, something called necrotizing enterocolitis. We have late onset sepsis and chronic lung disease, which is associated with dysbiosis. And this is seen primarily in our preterm babies, but then later on, you can have these early dysbiosis causing behavioral disorders such as autism. You can have them lead to autoimmune conditions such as type 1 diabetes, multiple sclerosis, and even obesity and metabolic syndrome. So here is another cartoon showing the pathophysiologic overview at the intestinal barrier. And this is something that we think of as associated with the pathogenesis of necrotizing enterocolitis and also late onset sepsis. So you can have a genetic predisposition to begin with, altered microbiota, and an immature gastrointestinal barrier that we see in our preterm babies, and that causes exaggerated inflammation and intestinal injury, leading to intestinal necrosis that we see in babies with necrotizing enterocolitis, for an example. This is a study that was done a few years back, and I was one of the authors on this study with Dr. Mohan Pami from Baylor College of Medicine as my co-author. And what we did in this study was we were able to get data from 8 different neonatal intensive care units in the U.S. that had evaluated the microbiome prior to the development of necrotizing enterocolitis. And here what we see on the left side of this slide is control babies, and these are babies who developed necrotizing enterocolitis. And what we see is a change in colors over time in the NEC babies on the right here, but these colors do not change in the control babies. What is happening? The blue shows an increase in a phylum of bacteria called the proteobacteria. And these are higher in the babies who subsequently develop necrotizing enterocolitis. And here we see a decrease in this yellowish gold. And these are bacteria called the firmicutes. These are good bacteria, primarily gram-positives, that produce certain metabolites that are considered to be very healthy, such as short-chain fatty acids, acetate, propionate, and butyrate. And here we just see some of the bar graphs of the differences between NEC and control babies. So before the development of necrotizing enterocolitis, we see this association with a different kind of a microbial environment. What may be a cause of this? Well, some of the most commonly used drugs that we use in our preterm babies are antibiotics. Here we see ampicillin and gentamicin. Excuse me, very commonly used drugs in neonatal intensive care. These can have an effect on the types of microbes in the gastrointestinal tract. Here we see this cartoon showing the antibiotics wipe out the normal, balanced microbial community, which leads to decreased species diversity, altered toll-like receptor signaling, and immune dysregulation. Even the use of only 2 days of antibiotics can change the microbiome at 4 weeks and 8 weeks after birth. And here's a study that from several years ago that showed here are treated babies, treated for 2 days of ampicillin and gentamicin, and here are controls. And you can see the colors differ between the treated and the controls. Here's week 4. Yellow is considerably high here. What are the yellows? These are the proteobacteria in the treated babies compared to the controls. Same thing holds true even after week 8, 44% versus 33%. This is telling us that the proteobacteria or the bad bacteria are present at week 4 and week 8 after only 2 days of treatment with antibiotics in our preterm babies. There's also the concern about the use of H2 blockers. And there's studies that show, and this is an example of one of these studies that show that H2 blocker, ranitidine, is associated with infections, necrotizing enterocolitis, and fatal outcome in newborns. What happens with gastric acid inhibition, and why do we use these? Well, in the past, it was thought that babies who are having apneas and bradycardias need to have H2 blockers because the apneas and bradycardias were being caused by acid reflux. We have found that that is not really the case, that these apneas and bradycardias, for the most part, were not being caused by these reflux episodes. However, gastric acid inhibition changes the pH of the stomach and allows different growth of bacteria. How does this happen? Here's a paper that was published several years ago that in Journal of Pediatric Gastroenterology and Nutrition, where here a baby was being given IV H2 blockers. And here's the types of bacteria that we see that are predominant with the use of IV H2 blockers. Proteobacteria are very high. The firmicutes down here are very low. Remember, the proteobacteria are the bad guys, the firmicutes are the good guys. H2 blocker was stopped. Proteobacteria go down, firmicutes go up. H2 blocker was restarted. Firmicutes go down, proteobacteria go up, showing a very interesting association with the types of microbes and the use of H2 blockers. And here's a slide that shows the microbiota that are present in preterm babies when you are giving total parenteral nutrition and not putting food into the gastrointestinal tract. Here on TPN, we see this largely dark blue. What is the large dark blue compared to in the TPN versus the control? These are the firmicutes, and the green are the proteobacteria. And we see here that with TPN, a lot more proteobacteria than in the controls. This is just a different way of looking at this with a bar graph. TPN, a lot more green than in the control. So again, the proteobacteria, the green, are the bad guys, and there's more in TPN versus control. So feeding babies appears to improve the microbial environment of the gastrointestinal tract. What about these bacteria in the development of bronchopulmonary dysplasia? Here we see these colors are somewhat similar on day 3 to 7 between BPD and control babies. And now these are intestinal microbes. On day 14 to 28, we see changes in these colors. The blue here represents the proteobacteria, and we see much higher proteobacteria in the BPD babies than in the controls. And here we see diversity of bacteria, relatively low diversity in the gastrointestinal tract versus controls in the BPD babies. So we can really think about the antibiotics and some of the manipulations that we do to these babies that can change the microbial environment toward what is called a dysbiosis. And that is associated with certain pathologic processes, such as what we call necrotizing enterocolitis or bronchopulmonary dysplasia. So how can we prevent and treat this dysbiosis? Well, one thing that we can do is avoid the overuse of antibiotics and unnecessary drugs that may affect the microbial ecology of the gastrointestinal tract. The use of the baby's own mother's milk has numerous bioactive factors, including good bacteria that may play a role in the advantageous colonization of the gastrointestinal tract. Manipulation of the GI flora using pre, pro, and postbiotics, and I'll talk about this shortly. And vaginal microbial transfer for C-section delivered babies. This is something that is highly controversial and is not yet recommended until further studies are done, and same thing with fecal transplantation. Now, what are pre, pro, and postbiotics? Well, a prebiotic is something that is a non-digestible food ingredient that promotes the growth of beneficial microorganisms in the intestine. A good example of a prebiotic is human milk oligosaccharides. And we think that there are at least 200 different human milk oligosaccharides present in human milk that may promote the growth of beneficial bacteria. These human milk oligosaccharides are not absorbed or digested by the human, but they are absorbed and digested by the bacteria, which can produce certain metabolic products such as acetate, propionate, and butyrate, which can be very helpful for the gastrointestinal tract. Probiotic is a microorganism such as lactobacillus that when consumed maintains or restores beneficial bacteria in the gut and the digestive tract. And postbiotics are soluble factors such as butyrate, acetate, propionate, tryptophan metabolites, indoles that are secreted by live bacteria that can provide physiologic benefits to the host. Now, what about probiotics? What is the role of probiotics in the prevention of necrotizing enterocolitis? And this was the original topic that I was asked to talk about. And I'll just mention talk about this for a couple minutes. What about the routine use of probiotics in neonatal intensive care? And are we there yet? And I can say there are countries, Japan, Australia, several countries in Europe that are already using routine probiotics. But I think that there's still a lot of controversy about whether we should be using probiotics or not. There are probably at least 100 different probiotic preparations available. And this is something that we have to take into consideration when we think about some of the studies that have been done. And this is a classic study that was done and reported in Pediatrics in 2010, which really began to make us consider the use of probiotics routinely in preterm babies. And in this meta-analysis, there were 11 different studies that were evaluated. But in these 11 different studies, 10 different probiotic preparations were used. So here it looks like this favors treatment with probiotics in the prevention of necrotizing enterocolitis. But does this tell us which probiotic we should be using? And I can tell you that in this particular study, there was no benefit in babies less than 1,000 grams. Now, in this meta-analysis, the risk of neck and death was considered to be lower in the probiotic group. Sepsis did not differ, and there was a commentary in this that came along with this meta-analysis that suggested it may no longer be ethical to not use probiotics in preterm infants. Well, I was asked to comment on this in the Journal of Pediatrics, and this was the commentary, Routine Probiotics for Premature Infants, Let's Be Careful. And there were many reasons for saying, let's be careful and proceed slowly and carefully before we jump into this. In the United States right now, about 15% of neonatal intensive care units are using probiotics. But 90% of the probiotics being used in the United States have never been evaluated for safety or efficacy. And this is potentially problematic because we put all probiotics into the same basket. And we have to be thinking about a much more narrow approach. Which probiotic is actually the most beneficial? Because of this, numerous different probiotics were being used, and at Yale University several years ago, there was a baby who died of mucormycosis following the use of a contaminated probiotic preparation. And so the CDC and the FDA investigated this, and they suggested that we needed to stop the use of this particular probiotic in preterm babies. So one of the problems is that probiotics are not considered a drug. They are considered more of a food. And what that does, it leads to not very good quality control. Now, what about prospective randomized controlled studies? The largest study so far was done in the UK, and this is the UK PIPS trial done by Costello and colleagues, double-blinded, randomized, prospective. It was adequately powered for necrotizing enterocolitis, and the results showed no difference in neck, late-onset sepsis, or death. Again, I want to stress the concern that probiotics are being put out there as a food supplement rather than a drug, and preterm babies are highly susceptible babies for potential problems. If you want to have something that is truly safe on the market, it should be considered a drug if you want to say that this is preventing a disease rather than it's just good for you. Foods can be sold by anyone and not subjected to rigorous standards. So the American Academy of Pediatrics, just in the past year, came out with this statement on the use of probiotics in preterm infants. And I'd like to read this to you. This is the highlighted portion of this abstract. Given the lack of FDA-regulated pharmaceutical-grade product in the United States, conflicting data on safety and efficacy, the potential for harm in a highly vulnerable population, current evidence does not support the routine, universal administration of probiotics to preterm infants, particularly those with a birth weight less than 1,000 grams. So I'd like to conclude with what lies ahead. With our refinement of knowledge of the microbiota, intestines, systemic interactions, we need to pay an even closer role to perturbations in the intestinal microbiota. There are things we can do to prevent dysbiosis, such as more judicious use of antibiotics. We need to learn more about probiotics, the right kind of nutrition, and other forms of microbial interventions. The environment of the infant, such as maternal contact, is very important. And some of the intensive care interventions, drugs that we use in our preterm babies, may cause dysbiosis, and we have to be very careful about this. And there are disorders related to intestinal dysfunction, such as BPD, and later on in life, autism, autoimmune diseases, depression, and anxiety, which have been linked to dysbiosis. And we're just beginning to understand these relationships. And in the future, multiomics and artificial intelligence techniques will help. And I will be discussing a little bit about this in my next lecture. Thank you for your attention.
Thank you very much, Dr. Neo. I think for the sake of time, we may proceed for the second lecture and then we conclude with a few questions after that.
Sure. Okay, can you see this slide okay? This is my other presentation.
Yes, it's very clear.
Okay, wonderful. So this lecture is titled Nutritional Strategies for Preterm Infants. Is there a place for precision nutrition? I talk a lot about nutrition in preterm babies, and I talk a lot about what we are doing right now and what we should be doing and the kinds of nutritional guidelines we should be having. But this lecture talks a little bit about where we might be going in the future. And this relates to something that we call precision nutrition. And over the next 15, 20 minutes, I'm going to give you a brief background on artificial intelligence and multiomics. And how can we mesh these with diagnostics and therapeutics in neonatology? And how can we use these to improve definitions for various problems in preterm infants, including intestinal dysfunction, and providing precision nutrition, and then get into the future? Well, when we talk about the future, sometimes we want to talk a little bit about the historical perspective. And in the 1940s, this gentleman here, Alan Turing, said this statement: I propose to consider the question, can machines think? Alan Turing is considered by many to be the father of the modern computer. And I think that many of you probably recognize the fact that Alan Turing was a cryptographer who was able to use cryptographic and mathematical techniques to break the Enigma code in the early 1940s that helped the Allies win the war against the Germans in the early 1940s. And we've come a really long ways since Alan Turing's time in terms of computers. So Now we are in 2022, and a device worn around our wrists carries exponentially more computing capability than devices that required large, cooled rooms in the 1950s. Facial and voice recognition, the ability to connect classrooms worldwide as we're doing right now, and the integration of human cognition with artificial intelligence are all examples of these advances. Here in this slide, I'd like to just give you a little bit of a philosophical perspective of where we've been in the past, where we are now, and where we are going in the future. And I'd like to relate this to what we do in terms of nutrition for our preterm babies. And in the past, we've used a lot of intuition-based medicine. So in the 1970s, 1980s, when neonatology was first developing, we were also just beginning to develop parenteral nutrition, TPN, for these babies. We were just beginning to understand how to provide enteral nutrition for these babies. But we had a lot of concerns, and many babies in the 1970s, 1980s, and even 1990s were being highly undernourished because we were afraid to provide the kind of nutrition that was available to them. So with TPN, we were going very slowly with proteins, with lipids, and it took a week to 2 weeks before we were able to get to full parenteral nutrition in some of these babies. Similarly, enteral nutrition, we would only provide very, very tiny amounts of enteral nutrition, if any at all, for weeks. And this was considered to be a real problem in the past. Now, with evidence-based medicine, we are beginning to be a little bit more liberal in terms of providing both parenteral and enteral nutrition to these babies. And so many babies are up to full enteral nutrition within the first week after birth, even if they're only 1,000 grams. And that is based largely on both the retrospective and prospective clinical trials. But in the future, we will be using precision-based medicine and algorithms to guide us. And the reason we are making some of these changes is because the present we are aiming at the average. We are using Gaussian statistics looking at the mean. And in the future, we will be looking at babies more individually and what their needs will be. So, one of the tools we will be using is artificial intelligence. And what is artificial intelligence? It's the ability of a digital computer to perform tasks commonly associated with intelligent beings. And a programmer constructs an algorithm by generating a set of rules, expressing them in programming language, and using a computer to implement those rules. And the computer figures out patterns via a model that can be used to predict future patterns. And some examples of artificial intelligence. I think that we are all familiar with this. Netflix and also Amazon. They seem to know what kind of movies people like and what kind of books people want to shop. So they actually predict what kind of book that, and I see this all the time, what kind of books I like to read, okay? When we talk about categories of AI, I'm not going to get into all of these in this lecture because I just don't have the time, but these are just some of the examples of categories of artificial intelligence. And if you'd like to read about this, we recently published a paper in Pediatric Research in July of 2022 talking about these categories of AI and how they relate to care in the pregnant mother and in premature babies. So many examples of artificial intelligence across the lifespan: embryo selection for IVF, genome interpretation in sick newborns, assistance in reading of scans, slides, and lesions. We are now beginning to recognize that the artificial intelligence tools can be just as good, if not better, than clinicians in diagnosis of retinal problems. They can be used to predict various forms of pathology in our patients, including babies. And so this is where we are going in the future with artificial intelligence. And here's some examples of use in neonates. And there was a study that was published just recently in the Journal of Pediatrics, European Journal of Pediatrics, that was done to look at premature babies over the entire spectrum of preterm babies. We are now saving babies who are 22 weeks gestation, and we are putting them into the same category of preterm babies as babies who are 36 weeks gestation. And this is wrong. We need to have better phenotyping of preterm infants, and using machine learning and artificial intelligence techniques, this is now possible. And here is an example from this paper called hierarchical clustering. And this is what is called a cluster dendrogram. And in this cluster dendrogram, they were able to separate different kinds of premature babies into different clusters. And this is going to be very helpful for us to not say that these are all the same, that we can begin to have this a certain phenotype over here that we can focus on more readily than this phenotype, and then begin to look at how this relates to pathogenesis of disease. Now, I'm going to quickly give you a quiz and talk about necrotizing enterocolitis. I'll get into this in a lot more detail in my lecture tomorrow. But I'd like you to think about, please define necrotizing enterocolitis. We do not have a good definition for necrotizing enterocolitis. And we're beginning to recognize that necrotizing enterocolitis is not even a distinct disease. It's more of a diagnosis. And this Bell's staging criteria that we use do not even really, even though we call this necrotizing enterocolitis, babies with Bell's stage 1 and 2 do not have intestinal necrosis. This is problematic, and we don't have a clear understanding of the pathophysiology, largely based on the problem that we have in defining this. And so I think we need to start all over again and redefine intestinal injuries and feeding dysfunctions we are calling NEC using some of these technologies. So one of the things I think we need to do in the future is do what the study that I just talked about. We need to separate intestinal dysfunction into different clusters before we are able to actually look at the pathophysiology of NEC. So here's the historical perspective. We have been led astray with this problem, largely because we don't have a good definition. We have animal models that don't represent the disease we see in preterm babies and narrow focus on individual pathways rather than systems. This is a paper that came out just a couple of years ago, defining necrotizing enterocolitis, current difficulties and future opportunities. Here it is highlighted. In this review, we summarize 8 current definitions of NEC. If there's 8 current definitions, to me, that means we don't have a good definition. And this is highly problematic. And so this is one of the reasons we have to go back and begin to do this clustering. There are many different, more discrete entities that have been described as necrotizing enterocolitis, such as cardiogenic ischemia, variants of food protein intolerance, spontaneous intestinal perforations. So these are all problematic, and what we do need to do is exactly what is seen in this slide, this clustering type of analysis that we are just beginning to do. And we have not yet published this work, but we have some very preliminary data that suggests that babies with intestinal dysfunctions and feeding intolerances, et cetera, can be clustered into different categories, and we can begin to look at these separately. And how do we go about looking at these different phenotypes separately? Well, we can begin to use these developing omics technologies. And by omics, we are talking about the genome, the microbiome, we are talking about the transcriptome, metabolomics, etc. And one of the ways we go about this is we have to collect samples, lots of samples from our premature babies, feces, saliva, blood, urine. And we have to do more than just one simple omic technology. We have to do several different omics technologies. We have to look at metabolomics, the microbiome, immune and inflammatory markers, put them all together in something called network analysis. And that will help us better delineate the disease, discover biomarkers for each one of these different phenotypic clusters. And that will then help us lead to personalized therapeutic interventions. So here is, in terms of intestinal dysfunction, we need to think about NEC as not a discrete disease, and that we can begin to use some of these clustering types of techniques and artificial intelligence and multiomics to actually study the pathophysiology of individual clusters and preventative therapeutic measures. And what about personalized nutrition? Do we all respond to the same food intake? There's studies that show that even when you look at twins, and this is a study that was published in Nature Medicine just a couple of years ago, looking at a large number of twins being fed the same diet, but even being fed the same diet, they had different postprandial responses, such as blood triglycerides, glucose, and insulin responses. Those were all found to be secondary to the microbiome because these twins may have had a different microbiome and so responded differently because of their microbiome. So we have to begin to think about precision nutrition, even starting before birth. And the mother's microbiome is very important, because the mother's microbiome produces certain metabolites that get to the baby. And these metabolites can interact with the baby's gastrointestinal tract and can have epigenetic effects that can cross generations. And this is very important to begin to think about this during pregnancy and even before pregnancy. So why personalized nutrition in preterm babies? 23-week preterm baby is very different than a 29-week preterm baby. And how we feed and nourish this baby is going to be very different than how we feed this in the future. One size does not fit all. And there are various adverse outcomes that are associated with suboptimal early nutrition. And rather than aim for the mean, we are going to begin to aim for what is best for this baby compared to what is best for that baby. And this is where the multiomics and artificial intelligence will begin to come in. So here we have this 25-week AGA baby, 38-week IUGR, 38-week LGA baby. And obviously, the future is going to help us be able to provide precision nutrition for each one of these babies. What do we currently do in terms of monitoring of nutrition? We use growth curves. Here's an example of some growth curves. Here's a baby who is faltering on the growth curves. And growth curves can be very helpful, but if you see this kind of faltering, and if you try to respond, it may already be too late. So we need to be able to predict this before it occurs. With artificial intelligence, with multiomics, we will be able to predict this growth faltering before it occurs. And we are in the very early stages of this. Here's a paper that was published just recently in Biomedical Informatics. We were involved with this study. This involved a large number of babies from the UK and also the United States. And in this study, we were able to develop a model that integrated clinical and microbiome data to improve our ability to predict growth failure when compared to models using clinical data only. So this is one of the earliest studies to look at where we are going with this in the future. And in terms of summary for precision nutrition, we are making some progress in finding associations between early nutrition and short and long-term outcomes. But the mechanistic and causal natures of these associations are not well understood. But with these newly developing technologies, we will be able to get a much better causal understanding of how we are nourishing our preterm babies and our moms, and how we can personalize this nutrition. And we are in the phase right now where clinicians by themselves cannot do this, medical scientists by themselves cannot do this, but we have to have communities of people working together, clinicians, basic scientists, engineers, and bioinformaticians working as a team to be able to make progress in the future. But I think we will be getting there. I want to thank you for your attention.
Thank you very much, Dr. Nu, for very nice 2 lectures, actually, back to back. So the floor is open for questions if anyone is having a question here from the audience or online as well. Yes, I have one question here.
Thank you, Professor No, for these 2 nice lectures. I have actually 2 questions. One for the first, regarding, is there a difference in the microbiome between the mother's own milk and the processed milk, or what is called banked milking? And the other question is, in regard of jaundice babies receiving phototherapy, does the phototherapy change the dysbiosis also and affects the microbiome in these babies?
Okay, so for your first question, the question was, is the microbiome in babies with fed mother's own milk versus donor milk or formula different? Yes, I think that there have been several studies now looking at this, and the microbial environment is different in the babies fed donor milk versus baby's own mother's milk. I think we have much more work to do to be able to understand the actual consequences of this, and using techniques that involve more than just looking at the types of microbes that are present, but what they are doing using these multi-omic technologies, I think will help us tremendously in the future better understand what the potential effects of these differences in the microbiome of mother's own milk versus babies who are fed donor milk or formula are. Your second question had to do with phototherapy, and I have to very simply answer that with, I don't know. I am not aware of any studies that have looked at phototherapy and the effect on the microbiome. But I wouldn't be surprised if there is some effect on the microbiome, largely based on the fact that one of the mechanisms of the way that phototherapy works is that you cause the breakdown of the bilirubin in the skin to more water-soluble products. These water-soluble products get into the gastrointestinal tract, and you can actually increase the fluid environment of the gastrointestinal tract. And some of these babies stool more if they are being given phototherapy. And so more passage of stool may alter the microbes. But I can only guess on that because I have not seen studies.
Okay.
Thank you very much for your answer. Any other question here? Yes, we have one question from the right side.
Thank you, Doctor, for your interesting presentation. Actually, the microbiome is a very interesting topic, and a lot of studies are running on this topic. For the microbiome in mother-own milk, is it differ with the period of gestation? For example, for 25-weeker versus 30-weeker preterm labor, and is the component of microbiome differ? As I know, it differ with time in the same mother, but how long it take time to be different from certain component of microbiome to other? Is it taking weeks or months? The other question. For example, sometime we have a twin baby, they are preterm both, and they are receiving the same breast milk from their own mother, but one of them may develop necrotizing enterocolitis and the other not developing. There may be other factors like in-hospital infection and etc. But my question, is there any study that the twin preterm who receiving the same breast milk from their own mother, they may have a different microbiome in their intestine? Thank you very much.
These are great questions, and I think that your first question has to do with the microbiome over time in the same mother. And as you mentioned, yes, it does change over time, but the microbiome in the same mother, at least the studies that have been done, is different than other mothers. Okay, so between mothers, the microbiome is very different. But within the same mother, over time, there are differences in the microbiome, but they are not as different as they are with other mothers. Okay, so we have that information in the literature. The microbiome in the mother is also highly dependent on her diet. So in other words, if she is taking medications, or if she's eating certain kinds of food, high carbohydrate at one point, and changes largely to meat, then her microbiome is going to change. So it's highly dependent on what she is eating at the time, and also the metabolome may differ markedly because of what she is eating and what these microbes are being exposed to. And so this is something that we are just beginning to learn about, and we cannot just think about the types of microbes that are there, but what they are actually doing. So this is a very exciting area for studies. Your second question had to do with twins and necrotizing enterocolitis. And there appears to be a predisposition for the genetic predisposition for the development of necrotizing enterocolitis. And there have been genomic studies looking at this. And some of the studies do suggest that there are certain DNA loci in areas, inflammatory pathway areas in the DNA that seem to be affected in babies with who subsequently develop NEC. But the problem is that it is not highly consistent. And this is highly problematic, largely because of our problem in defining necrotizing enterocolitis. And I'll talk about that a little bit more in my lecture tomorrow. So that is highly problematic. Now, you asked if one baby is getting human milk from the same mother, and it's a twin. It could be certain environmental differences, and even identical twins may not have the exact same gastrointestinal tract, or microbes in the gastrointestinal tract can be exposed to different types of environments, different nursing staff, for example. So I think that this can certainly happen, and there's a heterogeneity. I mean, we see babies who develop who are twins where one of the twins develops bronchopulmonary dysplasia. And I think a lot of that has to do with environmental differences. I hope that at least partially addresses your question.
Yeah, thank you very much, Dr. Nu. I will conclude with the last question, or last few questions, one from online, and actually I have my own. One of the online question were, what's the best probiotic? So that comes to the next question, actually, which is really difficult to mention, which is the best one. We're not here to advertise for probiotics or something. But again, I'm having few different questions. Are we really using the right growth chart for preterms? We just anticipate that preterm will grow like intrauterine life. In real life, they are losing around 10 to 20% of their life, and that's not shown in the chart. Are we using the right chart? Second thing is the probiotic. Actually, probiotics are not the same, and we all know that. And then the American Academy of Pediatrics made a recommendation based on non-homogeneous use of probiotics. And even the same probiotics, with time, when they started the probiotics, it was having certain composition. With time, when they rechecked the probiotics, the composition of bacteria or bacterial composition of that probiotics, of that brand, completely changed, despite the same ingredients, same everything, which is, again, manufactured problems. Is this conclusion right at this point or not? Then you just try in your research to link the microbiomes and the growth together. Do you think we should link the breast milk composition or breast milk calories? We know that the calories in each mother breast milk is different than the others. Do you think that it's better to link that or measure the calories in each breast milk? Because we did that and we found that some of the mothers are having actually around 55 to 58 kilocal in 100 ml, and some of them are actually providing more than 63, 64, 65 in 100 cal, in 100 ml, kilocal in 100 ml. So breast milk is not really the same. Even if we give the breast milk, it's not the same. What is your comment on that, please? And we'll conclude with this, please.
Okay, great questions, and I wish I could give you an answer on what is the best probiotic, and I honestly don't know, but I can give you my personal opinion on what we should be doing, and if we are going to be using probiotics for prevention of any disease in preterm babies. I think the right way to do this is to evaluate the probiotic in a prospective, randomized, controlled safety and efficacy trials. And do that very carefully with clearly defined outcome definitions. And that is, I think, the most promising and, to me, clearest way to be able to get to a probiotic that will potentially be safe and beneficial, that I would feel totally happy with. But I don't think that we are quite there yet. So that's my answer on the probiotic. The question about the breast milk, and there are huge compositional differences from different mothers. I totally agree. And there are differences in the way certain babies respond to breast milk. And I think that one of the things we've been doing is we have been looking at the breast milk composition without thinking about the baby being LGA, the baby being SGA, the baby being IUGR. We need to look at several factors. And this is where I think the machine learning will be very helpful. If we have a compositional analysis of the mother's milk, that looks at more than just macronutrients, and I think you referred to primarily calories and macronutrients. We need to begin looking at those plus the bioactive components of human milk, because they can play a major role as well. So we have a long ways to go, but I think we are in the process of developing some of the tools that will help us do this in the future. And I think neonatology and nutrition and how we care for babies 10 years from now will be very different than what we are doing right now.
The third one was about the growth chart we're using right now. Do you think it's appropriate or not?
I think that for now, it is the best that we have, but we can do better.
Thank you very much, Dr. Noor. Thank you for your valuable time, and thank you for being with us from very far in the United States. Thank you for all the audience on site and online, and we will conclude our session today. Thank you very much.
Thank you.